Glaucoma is the second most common cause of blindness worldwide. And in India, at least 12 million people are affected by, and nearly 1.2 million people are blind from the disease. So the burden is huge. IOP is important and modifiable risk factor in glaucoma, and tonometry is the procedure performed to determine the intraocular pressure. I will limit my talk mostly to the tonometry. So a brief idea about the history of tonometers. In 1826, it is the William Bowman who used to digital tonometry in routine clinical practice. And in 1863, Von Griffith designed the first tonometer. In 1885, it was the Makalakov who designed the Replantation tonometer, and 1905, Seuss designed his indentation tonometer, and that has made tonometry a routine clinical practice. This is the Von Griffith tonometer, and mostly the tonometers are of two types, contact and non-contact tonometer. In contact tonometer, it is indentation in Seuss tonometer, and applanation with variable forces, Goldman applanation tonometer, Perkins, tonopane, and pneumotonometer. And with constant forces, Makalakov. And non-contact tonometer is Pulsar. In the picture, we can see that first one is indentation, Seuss is based on that, and the second picture is applanation tonometer. This is the most accurate method of IOP estimation manometry, but it is measured by inserting a cannula directly into the anterior chamber, which is connected with a manometer, but this is not practical clinically. This is a Seuss tonometry. We all know that it is based on the principle that if a fluid-filled sphere is indented by plunger, the plunger will sink in the globe till the pressure of the plunger is equal to the pressure inside the globe. Oh, this is all about principle. Advantage of this is cheap, easy to use, and does not require slit lamp. And its advantages are IOP is influenced by ocular rigidity. Low ocular rigidity in case of high myopia, myotics, masculitis, and thyroid ophthalmos, falsely low IOP, and high ocular rigidity like hyperopia, macrophthalmos, and vasoconstrictors, falsely high IOP. Now this is the important because mostly we all are doing it, and it is based on the Imbert-Fix law, which states that the pressure inside an ideal dry thin-walled sphere equals the force necessary to flatten the surface divided by the area of flattening. This is all about technique. Important point here is the angle between illumination and the microscope should be around 60 degrees. A pattern of two semicircles seen one above and one below the horizontal midline, and the dial on the tonometer is rotated to align the inner margins of the semicircles. That is important. And this is about the semicircles and biprism of the probe. This is important. Sometimes we see the thick Myers, and that will lead to overestimation of the IOP, and it is due to excessive staining with the fluorescent stain. And to correct this, the excessive fluorescent stain should be washed out. In case of thin Myers, it will lead to underestimation of the IOP, and it is due to measuring the IOP over a long time period. So to correct this, ask the patient to blink few times. Sometimes there is too large a applanation surface. This is due to forward moving of the slit lamp, and to correct this, withdraw the slit lamp until the regular pulsating Meyer appears. Sometimes eccentric Myers, so proper centration of the biprism should be done. Unequal Myers, it leads to overestimation of the IOP, and correction is by proper height adjustment of the slit lamp. The sources of errors falsely low IOP in case of thin cornea, condyma with the rule of stigmatism, prolonged contact and repeat tonometry, because there is softening of the eyeball. And falsely high in case of thick cornea, steep cornea against the rule astigmatism. Sometimes we put too much pressure on the globe. That will lead to falsely high IOP. Sometimes excessive squeezing of the eyeball by the patient. It also leads to increase in the IOP, and in case of thyroid myopathy, because there is restriction of the extraocular movements. This is about Perkins tonometer. It is based on the same principle as that of Goldman, and being portable, so useful in measuring IOP in infants, children, bedridden, and sterilized patients. Now coming to the tonopane, the probe tip contains transducer that measures the applied force. It is based on the both indentation and applanation principle, and being portable, so useful in children, irregular surface and limited cornea, and through the amniotic membrane patch graft and even on the soft contact lensage. Eye care tonometer, it is an updated version of indentation tonometer, and a very light disposable sterile probe is propelled forward into the cornea, and the time taken for the probe to return to its resting position and the characteristic of the rebound motion are indicative of the IOP. The advantage are results are comparable to the Goldman implant tonometer and useful for screening purposes. And disadvantages are not useful in corneal scanning. Palpable tonometer, it is used in situations where other devices are not useful, like children, demented patients, and mentally challenged patients. Pressure on the eyelid produces retinal phosphines, and the force required to produce these retinal phosphines is proportional to the intraocular pressure. This is important. Dynamic contour tonometer, and this is the most accurate tonometer till date we have. And it is based on the principle that by surrounding and matching the contour of the sphere, the pressure on the outside equals the pressure on the inside. And it is IP displayed on the LCD screen. The DCT indicates the magnitude of difference between the maximum and the minimum IP of the ocular pulse amplitude. This is the graph of the ocular pulse amplitude, the difference between the maximum and the minimum IP, as shown as the ocular pulse amplitude. DCT is superior in accuracy to Goldman implant tonometer, and IP is not affected by corneal thickness, and it is also not affected by corneal refractive surgery. Now coming to the NCT, it is based on the principle that a puff of room air creates a constant force that momentarily flattens the cornea. And the time from an internal reference point to the moment of flattening is measured by and converted to IOP. It is useful in screening programs, and disadvantages are air puff can be startling. Now coming to the ORA, this is also important. It is an adaptation of the non-contact tonometer. It directs air jet against the cornea and measures two IP values, that is implant pressure 1 and implant 2, and two biomechanical values, that is corneal hysteresis and corneal resistance factor. And the difference between the first and second implant pressure is called the corneal hysteresis. Corneal hysteresis is a measure of the viscous dampening and hence the biomechanical properties of the cornea. The average of the two IOP provides a Goldman correlated IOP measurement. While the IOP varies over 24-hour period, but the hysteresis seems to be stable. And corneal hysteresis measures IOP that is less affected by the laser refractive surgery. Condon et al. Found that low stress values are at greater risk of glaucoma progression. This is the difference between the implant pressure 1 and implant pressure 2 is called the corneal hysteresis. If we don't have any tonometer, nothing to worry about. We have digital tonometry. If it indents easily, low IOP, firm to touch normal, and stony hard in case of high IOP. These are the criteria of ideal tonometer. For screening COs, eye care and NCT is good. For gold standard is Goldman implant tonometer. Most accurate till date is dynamic contour tonometer. Implantable tonometer, probably this is the future because we can record the IP over 24-hour period. And ideal tonometer is yet to come. Thank you.